I'd like to at this time introduce Dr. Emilio Exaire, chair of our cardiac catheterization laboratory and Mayo Clinic cardiologist. Dr. Exaire, please.
Hello, everyone. And I'm just going to try to, oh, there it is. That's me. How are you this afternoon? And we're going to talk a little bit about circulation problems and some of the causes and some of the things that one can do to actually get these problems a little bit better. So first of all, what I did in order to get this slides together, I actually got into our own Mayo Clinic webpage. And I actually asked it, so what are the most common causes of leg pain? And so being a trustworthy source, it came out with this explanation that you see here on the left side. So most of the lesions can result from regular wear and tear or overuse. Other problems that actually affect the joints and bones, muscles, ligaments, tendons, and sometimes even problems in your lower spine. Now, obviously, there is a good chunk of patients that actually have poor blood circulation or varicose veins that can actually give you pain in your legs. Now, if you see this delicious pie chart that I have here, we can actually see that if you divide them in, if you have 100 patients, you're going to have about 25 of them, if their complaint is pain in the legs, about a quarter of them are going to have some sort of arthritis. About a quarter of them, they have a bunch of other causes like the ones we just discussed, like injuries in joints, muscles, etc. About 1 in 10 patients actually come in with what's called neuropathic pain, which is a very complex pain syndrome that usually happens when your nerve endings have some damage. And the most common cause, perhaps in primary care and in cardiology, is patients that have diabetes. But there are some other causes, like if you had trauma at some point in time, or another typical neuropathic pain will be overuse injuries, like issues like carpal tunnel, that is very commonly seen in patients or people that actually work a lot on computers. Now, if you look at the bottom, and this is what we're going to be talking about today, mostly on the arterial side, you can have about a quarter of the patients over the age of 80 are going to have blockages that can explain pain in the legs. And about 15% of the patients that we evaluate are going to have problems in the venous system. Obviously, we're looking here at worst case scenario, or if you are older than 80, you have a very good risk, or a very good chance rather, of having a blockage in your legs. If you're a little bit younger, this decreases a little bit. So it's for people in the age group of 60 or so, it's about 10% to 15%, and it goes incrementally up and up and up until you get to the 80s, where almost 1 in every 4 patients that we evaluate in any given day can have a blockage. So you see, this is a very common problem. Now, here we go. Oh, sorry. There we go. That's the one I wanted to show. So you may ask, so what are the risk factors? Why am I growing these blockages? So there are several things that we need to know. On the left side of the screen, you'll see that we have the typical suspects for blockages: cigarette smoking and high blood pressure, diabetes and high cholesterol. And there are some of them that we cannot modify. So as I was discussing earlier, if you're older than 60, you kind of start having problems with plaque buildup. Or if you already have plaque buildup elsewhere, like let's say your coronary arteries or your brain, if you had a stroke, you actually have a bunch of risk to have blockages in your legs. And here are some of the interesting things that we should probably bring up more when we talk to our patients. Typically, circulation problems, in the past, we used to think that they would affect more men than women. And turns out that that is not true. It affects both men and women equally. Now, there is a higher risk if one is African American or Hispanic. You have a higher risk to actually have blockages rather than white Caucasian population. Now, if you look at the overall population in the United States, about 6.5 million people over the age of 40 can have a blockage or have problems with blockages. Now, it's very important to know if you have blockages anywhere in your body, but since we're talking about legs, well, the peripheral arterial disease, if you have a blockage in your legs, you have a really high risk for developing blockages in your heart or blockages in your brain that can result in either a heart attack or a stroke. So interestingly, patients that have blockages in their legs, they don't die because of the blockages in their legs. They die because you have other blockages that actually can increase your risk of dying, like brain or most commonly heart. All right, so this is one of those charts that we love to show to doctors. Don't feel intimidated by this one. It's actually just a way of showing how just a single risk factor, and we're going to just talk about diabetes. Remember, we talked about smoking, high blood pressure, being older than 60, having high cholesterol, all of those things. But diabetes is perhaps the most important risk factor for amputation. So you can see here that down, we call this the rate. So this is the amount of times that we see the amputation. And here in clear blue are patients that are non-diabetics. And here in solid blue, you'll see people that are diabetics. And you can see that if you have diabetes and are female, you have about 4 times more chance of having an amputation than if you don't have it. And we're just talking about one risk factor, 4 times more. If you're a male, things are much worse for us, 7.5 times more chances of having an amputation if you're a diabetic man. Same goes for Hispanics and Black non-Hispanics. You actually have increased risk when you compare it to people that are non-diabetics. And white non-Hispanic people also have up to 4 times more amputations. Now, if I actually showed you a similar graph for all of the risk factors, we will have the same finding where smoking increases your risk of amputation by 2 to 3 times. High cholesterol, 1.5 to 2 times. High blood pressure, 1.5 to 2 times. So if you have all the risk factors, all the trifecta of risk factors, your risk of amputation goes way high, way high. So this is kind of a scary proposition, because if we're talking about amputation, we're talking about a lot of issues that can actually come along with that. Mobility issues, family strain, because you need to have some help to move you around the house. Obviously, you need some, you're no longer independent, so you're going to need to have a lot more expenses to have people coming over to help you with even the small things like doing your laundry. So it's very, very important that if you have any of these risk factors, we pay attention so we don't get to have amputations. Now, you may ask, do you have the risk factors? So I actually gave you all the risk factors. So if you were actually going like, oh, I have this, I have this, I have this. Well, the first thing you need to do is actually go and talk to your doctor and see, hey, do you think I might have a blockage? And it's very important to do it even if you don't have any symptoms, because most of the patients actually that have blockages do not have any symptoms. So you need to talk to the doctors. And sometimes as doctors, we're like, well, maybe we don't need to look for this. But turns out that if we actually catch it on time, we can actually order a test or give you medications to try to mitigate, slow down, and sometimes reverse some of the plaque or of the blockages. So you may ask, is there a test that we can actually do to figure out if I have a blockage? And yes, there is a test, and it's very simple. It's called an ABI, ankle brachial index, and I'll show you a picture in a moment of how it looks. And it's super simple. It takes about 10 minutes to do it, and it gives us a bunch of information. And you may ask, is there a treatment? And yes, there is absolutely a treatment. Most of the times, we don't need to have the patient go to surgery or get stents or anything like that. We just need to manage all the risk factors so it doesn't get any worse, the blockage that we, or the potential blockages that we find. All right, so let's talk a little bit about this mysterious ABI. So the A actually stands for ankle, B for brachial artery, which is the arm, and an I is just an index. So we just make a simple division. So typically, if you recall, you go to the doctor and they take your blood pressure and we tell you, oh, it's 120, that's the number we're looking for. Yep, so let's say you have 120 on the right arm and 120 on the left arm. So we pick up the highest of the two. And then we actually measure your blood pressure in your legs. And we have two arteries that we can actually look for the blood pressure, and we pick up the highest one. And then we just make a simple division. So let's say you have 120 here and 120 here, then the index is 1. But the lower it gets in the ankle, the worse it is. So you can see that the normal falls between numbers of 1 or 1.3, and borderline abnormal falls between 0.9 and 0.99. You might say, well, what do we do if we have a borderline value? Well, it's still very important that we start taking really great care of ourselves if you have a borderline number. And this is perhaps the best that we can find. If you have all the risk factors and you have a borderline ABI, this is exactly the time that I would like to start treating you and not wait until I need to send you for surgery or anything like that. And then here at Mayo, we have some measurements that help us look a little bit closer to abnormal numbers. In general terms, anything that falls under 0.9, we call it abnormal for the American Heart Association, American College of Cardiology. There is no separation on how bad it is below 0.9. But for us here at Mayo, we use this scale that helps us tell you, hey, oh, this number is less than 0.5. So it's very severe. So we might need to do some more testing or keep a closer eye on the patient. Oh, sorry. There we go. So what about treatment? So we typically try to do a bunch of things at the same time. The first thing that we're going to ask you to do is try to lower your cholesterol. If you have really bad blockages, the best bet is by starting you on pills like statins. If you're already on statins, we go up on the dose so we can have as low cholesterol as possible. The lower, the better. We also ask you to stay away from animal fat so you can lower your cholesterol a little more naturally if you may. The other thing that we're going to try to work with you is control diabetes. And again, the diet is perhaps the most important thing. It's the most difficult thing because we do it 3 times a day. And so we have a lot more margin for error. And also medications or starting insulin, it's very important so we can keep a really tight control of your blood sugar. We also are going to ask you to control the hypertension and work with you. Sometimes we add more medications, and sometimes we need to do some lifestyle changes like avoiding salt, avoid excessive amount of caffeine, and actually take your pills. Sounds like it's a given, but sometimes if you don't take your pills, unfortunately, the blood pressure control is not going to be adequate. The single most important thing when you come see a doctor that you can do for yourself, the single most important thing, because it can essentially change your life within a second, is stop smoking. So even one cigarette can actually make your blood so sticky that it can give you a heart attack or a stroke or worsen circulation. It's very interesting that actually there was a study that actually showed that if you smoke even one cigarette, there is a substance called fibrinogen, which makes your blood really sticky, and it goes up really, really high for about 15 minutes after you finish your cigarette. So while you're sitting down finishing your cup of coffee and thinking about the cigarette or lighting one, actually your risk of heart attack or stroke is super high. So if you can walk out of a clinic after talking to your doctor and decide to quit smoking, is the single most important thing. And the other thing that's very, very, very important, and it's very difficult to stick with, is exercise. So most of the times we like to supervise you either at a hospital or guide you through home-based exercise programs. You need to actually touch base with your doctor or an exercise physiologist. Here at Mayo, we have terrific, a really great group of exercise physiologists. And we actually can help you with either treadmill or static bike protocols. So you can actually improve your chances of keeping your legs. So it actually exercise decreases the chances of amputation. And not only that, it also helps out with decreasing your overall risk of having heart attacks or stroke. And it also helps with symptoms. So if you exercise more, the symptoms of pain in your legs, they start slowly going away. All right. So what about surgery or angioplasty? And turns out that most of the times we don't need to do that right off the bat. We only do it if you really have bad symptoms. Let's say that you walk into the doctor's office and it's like, I cannot even sleep because of pain. Or sometimes we see foot ulcers or leg ulcers that are not healing. And those are the folks that we actually send immediately for surgery or attempt an angioplasty. It's very interesting because in the past, when we only had surgery, the scars were pretty big and the surgeries were significant. But nowadays, most of the procedures can be done through a very small incision. They are as small as the tip of this pen. So they're incredibly small. And so the recovery is very good, very fast. Unfortunately, sometimes we still need to send patients for open surgery. And should we need that, we can absolutely send you to some of the best doctors in the nation, bar none. Mayo, either here or in our sisters in Rochester and Eau Claire, we have some of the best surgeons that you will ever encounter in your life. So if you need one of those surgeries, you will be really well served. And here I'm going to open up for questions. And I think we had a few that were sent beforehand. So I don't know if we can get a hold of those.
So Emilio, this is Dr. Moline again. Hopefully you can hear me okay.
Yes.
There are some great questions that have come in, and I'm going to pose them to you at this point in time. I know you went over this during the presentation, but let's say I'm a patient. I'm concerned that I may have peripheral arterial disease. How would I go about this? Where would I start? Would I come to you? Would I go to my primary physician? And
that's a terrific question. And one of the problems that we have is that we're not teaching these in this problem as well as we could in during medical school and even in residency. So sometimes even your doctors can miss this diagnosis pretty easily. So typically you would like to start with your primary care, but sometimes we need to twist arms to get what we need. Sometimes you go to primary care or even internal medicine, or you go to specialists, and it's very interesting that we can, if we don't ask them, hey, do you think I have a blockage? Sometimes some of the doctors don't think about blockages, and it happens to everybody. It happens to even cardiologists. I've been involved in several cardiology fellowships in my life, and there are some of them that they don't even talk about this to the cardiologist. So you can be with a cardiologist, and sometimes they don't really know how to look for blockages. So it's very important as a patient that if you're going to take a message today from this talk is, first of all, if you have risk factors, if you have any of these, if you're older than 60, if you ever smoked or are a current smoker, if you have high blood pressure, if you have diabetes, if you have blockages elsewhere in your body, it's very important that your doctor sends you to do some studies for vascular problems. The single most important study that your doctor needs to order is what's called an ABI, the ankle brachial index that we discussed earlier. So I think it's very important as a community to also pressure a little bit your doctors to say, hey, do you think I might have a blockage? And your doctor should be actively looking for this. I think you can actually, if you have questions, anybody in the audience, you can actually get them through the, there is a chat box at the bottom, and you can actually send them out to us so we can actually answer them. So
yes, please send those through as you have them through that chat box, and we'll do our best to answer them as we move through them. Dr. Exaire, we have a few more questions. If I have this bad ache, my feet are hurting at bed at night, is this restless leg or is this ischemic pain? How, is there a way I can determine this? And how would you answer that?
So that's actually a very common clinical scenario that we find in clinic. So first of all, it's almost impossible if you don't have a good doctor and a good physical exam to just tell them apart, because the end result most of the times is pain, and it's a combination of pains like neuropathic pain and ischemic pain. So it's almost impossible to actually figure it out by yourself. So you need to go to your doctor and then tell them your symptoms, and then your doctor can help you with some easy testing to decide what kind of pain you have and the best treatment for that. And we have pain syndromes that are very, very difficult to treat, like neuropathic pain plus ischemia. So sometimes one could treat a blockage. And I always tell my patients when I treat the blockage, don't expect this pain to go away. It's going to improve 80%, but the neuropathic pain, it's going to persist for a few months, because the nerve endings, once they get damaged, they take a long time to recover and to get better. So that kind of pain is very complex to treat. And sometimes it's 2 or 3 things that are happening at the same time.
Excellent. Another question. Can I ever feel that blood clot in my leg that is life-threatening, that could kill me? Can you answer the difference? And I would guess that would come to the difference between a venous clot or an arterial clot. Can you explain the difference?
So clots can happen anywhere in your body. Interestingly, the heart will give you most commonly the blood clots that wind up giving you, for instance, strokes. But if you think about it, that kind of clot comes from the center of your body, from your heart, goes up into your brain. Sometimes it bypasses the brain and it goes down, and it winds up in some other areas of the body. So when you see a blood clot, you're obligated to look for, in the arteries, you're obligated to look for heart problems. Now, sometimes one needs to play detective, and it's not the heart, and it might be a blockage anywhere else in your body, and you name it. It could be somewhere in your aorta, it could be somewhere in your belly, it can be somewhere in your legs. So one needs to explore everything in the patient to figure out where that blood clot is going. Now, the blood, remember, once it gets to your feet, it winds up going back to your veins, right? Now, you can also have a blood clot in your veins. And those can also kill you. It's very interesting. Those will give you something called deep vein thrombosis and or pulmonary embolism. And the pulmonary embolism, what happens is the blood clot that starts in your leg, typically it goes back into the heart, and from the heart it goes and gets lodged into the lungs. And that could be also life-threatening. As a matter of fact, it's one of the most common causes of death in patients that are hospitalized. So if you have a blood clot on either direction, first of all, you will notice it. It's kind of difficult not to notice those. They are painful. Both of them are painful. Perhaps the one that hurts the most is the arterial one. But the venous one can also give you a fair amount of pain and swelling. So if you have pain or swelling or changes in color in your leg, either of those can be really a very important symptom that one needs to see right away in the hospital.
Yeah, can you expand upon that a little bit further? So let's say I am experiencing that severe pain and I have to drop my foot off the side of the bed to make that relief, or if it's discolored or markedly swollen. Can you just go over what I should do at that point in time if that were to be the case?
Yep. So that to me will sound like something that has to do with arterial circulation. Typically, patients that have a really bad blockage, they need to actually hang the foot from the edge of the bed to get some circulation going there. And the reason why you get circulation there is you start using, instead of the arteries that are pushing the blood down, the gravitational forces actually help pull some blood from up and then keep it down in the foot. Typically, the foot is going to change colors if you have it hanging or if you elevate it. And the pain gets a little bit better if you put your foot down at the edge of the bed. If you're having those symptoms and they are that severe that you cannot even sleep with them, those are very important that you check them right away with your doctor, because those are the ones that can actually wind up giving you, unfortunately, amputations or poor outcomes, even infections, things like that, or open ulcers.
Yeah. Dr. Exaire, I did a long day of exercise, strenuous exercise. Now my feet are really bothering me at night. Would this be consistent with peripheral arterial disease?
Well, that's probably not peripheral arterial disease. If you're working out really, really hard, there is actually one exception to the rule. Sometimes, if you look a lot, some marathon runners and people that actually exercise a lot can actually develop such big muscles that they start compressing the arteries. It's interesting. It happens very rarely, but most of the times when you have pain at night after you did your exercise, it's probably going to be joints or your some inflammation in your muscles, things like that. I mean, you really need to check that out with your doctors, but sounds like perhaps that's not a circulation problem.
Yeah, perfect. Okay, Doc, I've been diagnosed with peripheral arterial disease. Can you recommend a better exercise or what I should do? Or you had given some guidance in regards to that. Can you reiterate that for me, please?
Sure. And so most of the times, as I said, the exercise that works best is the one that's supervised by either a doctor or an exercise physiologist or nurses. And the reason for that is it's very difficult to stay on track if your legs are hurting, right? So I came in and because I cannot walk because my legs hurt, and you tell me to walk because, and so it's a little counterintuitive. So there are ways that we can actually make your legs hurt less when you are exercising. Some of them are medications, but most of the times what we do is we figure out what's the distance that you start experiencing pain at, and what's the speed when this happens. And if we can figure out those two things, then we can actually tailor exercise routines so you do not experience pain as often. And typically we start with 5 minutes of exercise at a very low speed. If you're walking on a treadmill, we typically do it at 1 or 1.5 miles per hour, which is a stroll. And then the idea is to increase little by little until we get to 50 minutes, at least 5 to 6 times per week. So you see, you will be eventually able to get to 50 minutes of exercise, which is tremendous if you cannot walk to the bathroom without pain, right? But it works best if you're supervised. So your doctor can see, hey, well, or your nurse can tell you, hey, well, slow down. What you need to do is this, or maybe switch over and try to do bike instead of treadmill. Some patients do much better with bike, and that's another important thing. Remember the first pie chart that we saw? You can have overlap of pain, right? So you can have arthritis plus blockages, or you can have venous problems plus arthritis, and so sometimes you cannot walk because your back hurts, and you also have a blockage, and we're asking you to do that. But perhaps you're much better if you're doing a recumbent bike. You can go for a lot longer. So that's why it's very important that you discuss this with your doctor. And then here at Mayo, we have, again, I'm going to reiterate that we have a terrific group of exercise physiologists and nurses that can help you guide that.
Sure. And on that same note, Dr. Exaire, if I have foot and ankle swelling constantly or throughout the day or at the end of the day, is that consistent with peripheral arterial disease?
So the answer for that one is complex. So swelling is a very unspecific finding. So swelling can happen from, you name it, liver disease, kidney disease, heart disease, or local problems, right? Like when somebody breaks an ankle, well, we're going to see swelling, right? So you need to actually go in and talk to the patient and see what else is going on, see if there are any symptoms of some other problems, and then we decide together, hey, well, maybe we're going to need to do some more testing, or, oh, well, this looks like it's a benign kind of swelling. We can just start with compression stockings or stuff like that. But you really need to go talk to a doctor about that, because swelling is really, it's telling me something's wrong, but it's not as easy as it seems to actually make a diagnosis.
Yeah, we had a very similar type question. Do compression stockings help relieve peripheral arterial disease? And I guess that would be kind of a complex answer also, but could you do the best to?
Yeah, and so it depends on how bad it is. If it's mild, you can do compression stockings, no problem. And if you feel better, there is no contraindication. But if your leg circulation is impaired, it's poor, and if you put compression stockings, it's going to get worse. So again, simple ABI, remember the numbers we were looking at, it can tell you, well, it's mild, let's try the compression stocking, see how you feel. But if it's like severe, whoa, no, we don't want any compression stockings here because it's going to make things worse. So again, we need to kind of bounce back and have a careful exam with your doctors.
Yeah. How about I have heel pain, Dr. Exaire, and when I walk on it, when I get up right away, it hurts. This individual, it sounds like they've maybe tried heel pads and others. Is that consistent with peripheral arterial disease, or would you consider other?
Well, the first thing that comes to mind with that is probably an orthopedic problem. That the heel is also kind of complex because you have bone, and then you have ligaments around, and then you have insertion of the very long tendon, the Achilles tendon that goes around that area. And typically when you have problems with arthritis or inflammation of tendons or whatnot, it hurts like, wow, terrible. I've had those in the past, and in the morning, it's almost impossible to walk, and then you walk a little bit more and it starts getting a little bit better. So that's a very typical problem with joints and maybe some inflammation in your fascia or the Achilles tendon. And those are different problems from circulation, gladly. Sometimes, again, they can coexist. There is a syndrome in runners that can actually affect one particular tendon. It's an overuse, but this is mostly for marathon runners, people that cannot stop running for whatever reason. Maybe the police is chasing them and you need to run. And so for those folks, you have you may have some problems that actually coexist with circulation, but typically that doesn't quite sound like a problem with circulation, but it's something that you may want to discuss with the doctor.
Yeah, thank you. How about my left foot is a little bit colder, and particularly during the warm season, it still remains cold. Could that be a blockage?
Cold.
What would you think?
Yeah, cold legs and cold feet. Again, it's an interesting topic. Sometimes, don't tell my wife, but sometimes she has really, really cold feet. And so anybody can have cold feet. But if you have a differential coldness in one foot or the other, it might be worth your while checking the circulation with, and you don't need a very expensive, sometimes you just need to have the doctor, hey, touch the pulses and that's it, right? Sometimes you might need the ABI to check for any particular circulation problems. But it's something that you may want to check. It's not very common that you have one foot colder than the other. Typically, it's both feet. And typically here in Wisconsin, it's the winter.
Yeah. You did a great job of talking about peripheral arterial disease. How does that work with carotid artery disease or other vascular disease? Can you just touch upon that once again?
Sure. So if you have a blockage anywhere in your body, so let's say you have blockages in your heart, the risk of having blockages elsewhere in your body goes up by a whole lot. So it's important that if you have had a heart attack or if you have had a blockage anywhere in your body, somebody needs to look for blockages elsewhere. If you have an abnormal bruit in your carotids, that will actually justify doing an ultrasound. And an ultrasound, which is a painless procedure, can tell us if you have a blockage. Now, you can have a whole lot of blockage in the carotid arteries, and we don't need to do anything other than treating your cholesterol, lowering your risk overall with the same things that we were discussing earlier, right? Like treating your diabetes, your high cholesterol, making you change your diet, lifestyle, quit smoking, things like that. But if you have more than 70–80% blockage in your carotids, then we typically have a surgeon take a look, see if they can clean it up with a surgery called endarterectomy, or sometimes we can do stents. They both work really great, but there are certain hoops that one needs to jump through to get a stent approved. So the typical standard of care will be surgical endarterectomy. And it's something that if you have even a maybe 40%, 50% blockage, you need to have follow-up with your doctors and continue having ultrasounds every so often, sometimes every year, sometimes every 3 to 5 years, depending on some other factors. But that's how we manage those patients.
Excellent. Thank you. Another question says, and this goes back to the leg discomfort, explaining how and when. Is leg discomfort worse at night? Is that common? Or when can you expect with peripheral arterial disease to expect pain?
So it depends on how bad the disease is. So if you're having pain at rest, that's very, very, very bad. That means that the circulation is already really affected. Typically, what happens is patients either have zero symptoms or they have something called claudication, which is you walk and you have a certain amount of cramping in your either your calves or sometimes your buttocks or sometimes your thighs. And it stops if you stop. So you walk a little bit, you get the cramping or pain, like if you were running for a whole lot and you need to stop, takes 2 to 3 minutes, it goes away and you can walk again, and then you need to stop again. So that's what we call claudication. Typically, that only a third of the patients actually have the symptom. And so you can have all sorts of other symptoms that can mimic a blockage, like sometimes neuropathic pain can come from a blockage. So you will need to, you will have pain worse at night, and it's your nerve endings telling you, hey, we have a blockage upstream. And sometimes you can have the extreme where patients are not having any pain and they can have a certain or a lot of blockages. So that's why even if you think you're doing fine, but if you have any of those risk factors, it's worth your while checking for any problems. And even if you're not having any symptoms, but even more so if you're having symptoms. So in a nutshell, you can have the whole spectrum of pain, rest pain in blockages. Typically it's bad. It's something that we need to take care of right away. If you're having problems walking, most of the times we have a lot of time to help you out with exercise treatment and whatnot. We don't need to jump right off the bat to do any kind of surgery or angioplasty.
Perfect. Thank you for that answer. Let's say I go through my ABI test and that vessels are non-compressible. What does that tell you?
Well, that is commonly seen in patients that have really bad or a high amount of calcium in the arteries. We see that in patients that have chronic kidney failure or diabetics. And what that means is that the blood pressure cuff can only compress so much, right? I think the best ones go up to like 280 millimeters of mercury. And that is a lot of pressure. I mean, you're going to feel 280, you're going to feel pain. But if this artery is so stiff, it's not going to compress it, which is what we need. We need to compress it. So once we release, we know what's the blood flow there. So if it's uncompressible, that only means that you have buildup of plaque or your artery is very hard to compress. And we need to do some other testing if we think that you have a blockage. Most of the times, the next available or the next test that we will order will be an ultrasound. Sometimes there is a way to bypass these very stiff arteries. Instead of using a blood pressure cuff that goes around your ankle, we use one that goes around your toes. And we actually measure the toe circulation. And that's very helpful. And we don't need to do anything very, very special. We just use that, the capability of compressing the toe arteries. And sometimes we need to do something more sophisticated, like a CT scan or anything like that. But if we get enough information with the issues with the toe blood pressure, that's perhaps all we need to do.
Sure. Well, hey, I've been diagnosed with peripheral arterial disease. You did a great job of talking to me about the medications I take, smoking. I'm exercising. Now that I'm exercising, what happens? Can arteries regrow? What happens? We've heard about that. Tell me some more.
So what exercise does is super interesting. The arteries that are blocked, they are blocked. Unless we unplug them, they are not going to miraculously open back up. So what we do is our body has the ability to create its own bypasses, its own alternative routes. And it's incredibly, it's an incredible thing because you can actually see over the years how you get more and more of these small channels that go around the main artery that's completely blocked. And exercise actually makes that more efficient, and it starts, it promotes growth of these extra bypasses that your body is going to create. So it's very important that you exercise. It's sometimes the pathway of least resistance is like, oh, well, I don't want to exercise. Can you open this one up? Well, turns out that exercise is perhaps more important than surgery, because I always tell this to my patients that I send for exercise treatment. I have seen patients lose more limbs after surgery than I still need to see someone that is exercising lose one limb, because it's much more effective than surgery. Because surgery, it can only bail you out for a few years. I mean, typically 10, 15 years. Same goes for stents. And but the arteries that you create, those are going to stay with you. So by promoting these extra channels, we gain a lot of extra benefits.
All right. Well, we've got one last question here, and then we'll conclude our program with a couple of slides here at the end. But Dr. Exaire, what type of doctor or specialist should I be seeing with these type of problems? Carotid artery disease, peripheral fluid flow concerns, swelling in my legs. And this is, we know we can go from acute, being emergency, down to something that's been ongoing for some time. How would you proceed?
So obviously, if this is a problem that's starting and ongoing, you can start obviously with your primary care doctor. And usually, and again, a tip of the hat for you, because typically our primary cares here are really good at what they do, and they will work with you to figure out what kind of problem you have and follow up as well. And there are a group of doctors like myself that can do either cardiology plus vascular problems. Some doctors only do cardiology, some others do cardiology plus vascular, and some other doctors only do vascular problems. And there are also vascular surgeons. So all of the above can actually see patients with blockages. And sometimes we collaborate very closely, because it's not as straightforward like one size fits all. We need to sit down and chat about how to manage problems with circulation, because sometimes it's not a very straightforward answer. So each patient is actually a little bit different. And but anybody that has vascular in their last name, so vascular medicine, vascular surgery, can actually help you. Your own primary care doctor can actually help you, and some cardiologists, not all of them, but some cardiologists can actually help with vascular problems.